Thank you very much. Good afternoon. Thank you very much for your attendance. Thank you for this nice presenting me. I want to express my deep-hearted gratitude to the organizing committee of the conference, Omics Group also, for inviting me to share in this distinguished event. I really benefit and enjoy too much these days from sharing and exchanging knowledge, and I benefit from seeing. I'm basically a psychiatrist, but there is many modalities of treatment of intervention for drug addiction I have seen in these days, and I benefit too much. Thank you. I'm from Egypt, and I want to, in the coming 25 minutes, I want to give a brief presentation about our research work, which was held in 2010 to 2011. It was about detoxification methods of benzodiazepine monodependence, application and comparison. As we know, benzodiazepines are medications, and they are psychoactive drugs that increases the effect of neurotransmitter gamma-aminobutyric acid at the GABA-A receptors, which produces sedative, hypnotic, anxiolytic, anticonvulsant, and muscle relaxant effects. Recent guidelines recommend benzodiazepines to be used for short-term periods when strictly indicated, and do not prefer their longer use because of their dangerous side effects, like, for example, dependency, cognitive impairment, unwanted sedation, reduced coordination, falls, traffic accidents, and so on. Management of benzodiazepine dependence involves not only short-term interventions such as detoxification, but also psychological intervention and rehabilitation programs. And we see many modalities in the other talks. Detoxification aims to get rid of the drug of dependence in a controlled and human fashion, and enhancement of treatment retention and detoxification success rates while reducing degree of discomfort. Although detoxification is viewed as an ineffective standalone treatment for drug dependence, it is a must for starting long-term abstinence-based treatment. Ordinary detoxification can be achieved by one of the two approaches of detoxification: abrupt discontinuation of drug use or gradual tapering of the drug. Abrupt discontinuation with the use of replacement medication during the withdrawal period, or gradual tapering of the drug. Benzodiazepine dependence is usually treated with tapering of the medication or by substitution by an equivalent dose of a long half-life benzodiazepine drug before tapering, especially when patients are difficult to be treated or have low compliance to treatment. However, there is no obvious evidence suggesting the optimum rate of tapering. Flumazenil is a medication commonly used in the treatment of acute benzodiazepine toxicity. It is usually known as benzodiazepine antagonist. Nonetheless, in chronic benzodiazepine users, it works as a partial agonist. Flumazenil has been shown to reduce the physical signs of benzodiazepine discontinuation and to reverse anxiety in benzodiazepine-dependent patients. The aim of this work, this study aimed to compare three different methods of detoxification of benzodiazepines and to show its differential effect on the control of withdrawal symptoms and relapse rate. This study was conducted on 45 Egyptian long-term benzodiazepine dependents, male patients, coming seeking treatment specifically for benzodiazepine dependence at the Center of Psychiatry, Neurology, and Neurosurgery, Faculty of Medicine, Tanta University. You see, this is Tanta. This is my town. It is near Cairo, the capital of Egypt. This is Egypt. It is near the north coast, near the Mediterranean Sea. And this is the logo of Tanta University. And this is the Neurology, Psychiatry, and the Neurosurgery Center. And this is the Faculty of Medicine, from which I was graduated. Medications used in this study: Oxybam, this is the trade name, and this is the generic. Oxybam, which is oxazibam, 15 milligram capsules. Seroquel, which is quetiapine fumarate tablet, 100 milligram. Anixate, 0.5 milligram of flumazenil in 5 ml aqueous solution ampoules. Tegretol, 200 milligram carbamazepine tablets, and triptizol, 25 milligram of amitriptyline hydrochloride tablets. These are the medications used in our research. Study design, grouping and phasing of the studied benzodiazepine-dependent patient. We grouped the 45 patients into 3 groups: Group A, Group B, and Group C. And each group passes through 3 phases of research, of treatment. The first phase is called the pre-treatment phase, which is 7 days. Second phase is the detoxification phase, which is 8 days. And then the follow-up phase is about 30 days. The patient in the 3 groups were shifted to oxazibam, were shifted their benzodiazepine into oxazibam in order to make patients homogeneous regarding benzodiazepam use. They are shifted to an equivalent dose of oxazibam. Regarding Group C, in addition to oxazibam, we give psychotropic medication for the aim to reduce symptoms of withdrawal symptoms in the withdrawal period, anxiety, fears, insomnia, convulsions, and so on. We give quetiapine, amitriptyline, and carbamazepine. During the detoxification phase, the Group A is called flumazenil group because we give flumazenil infusion plus oxazibam for the first 3 days, which is tapered from 30 milligram, from 60 milligram to 30 milligram to 50 milligram over 3 days only. And the rest of the 8 days, the patient was on flumazenil infusion. During the detoxification phase also, Group B patient started tapering of oxazibam till the end of the detoxification phase. The patient is receiving 0 dose of oxazibam. For Group C, there is abrupt discontinuation of oxazibam, and the patient was in a replacement therapy in the form of quetiapine, amitriptyline, and carbamazepine. Quetiapine and amitriptyline were non-drugs to treat anxiety and are used to control withdrawal symptoms during the withdrawal period. Also, we give carbamazepine to alleviate the possibility of occurrence of fits or convulsion during the withdrawal period, because many patients having a very high dose of benzodiazepine, and as we know, abrupt discontinuation of benzodiazepine carries the risk of convulsions in the detoxification period. During the follow-up period, all patients become benzodiazepine free, Group A, Group B, and also Group C, benzodiazepine free, but they were continued to use carbamazepine for 2 weeks, then tapered also. We collect the socio-demographic data of the patient, and also we determine the pattern of benzodiazepine use regarding the name of the drug, route of intake, age of onset of intake, duration of intake, regularity of use, daily dose, motives for intake, drugs currently used, and history of previous relapses. We did physical examination for all patients also, chest, heart, abdomen, and so on. Also, patients were subjected to psychiatric and psychometric evaluation. It were done at the end of the pre-treatment phase and on daily basis of the detoxification phase and also on the follow-up phase. We use the benzodiazepine withdrawal symptom questionnaire. Also, we use a visual analog scale to is as a subjective test to determine patient craving to benzodiazepine. We used Hamilton Anxiety Rating Scale, and also we used Hamilton Depression Rating Scale. Patients were also subjected to routine investigation, liver function test, kidney function test, complete blood count. Also, it performed immediately on admission before oxazepam replacement doses and after a stoppage of treatment. Then, toxicological analysis was done on admission before starting detoxification phase, at the end of detoxification phase, and on day 15 and 30 of the follow-up phase. We use the rapid screening test, the quick profile drugs of abuse, alcohol test device, a specific immunochemical reaction based on one-step in vitro test, and the VIVA-E analyzer, a homogeneous enzyme immunoassay technique used for semi-quantitative analysis of benzodiazepine and benzodiazepine metabolites in human urine. We found that the ages of the patient ranged from 22 to 60 years with no significant difference between the studied groups. All patients were current cigarette smokers, whereas the majority of patients were caffeine users. Regarding the type of drugs abused, the type of benzodiazepine abused, clonazepam was found to be the most abused drugs among patients, and it is the most abused drug in Egypt as a whole, then alprazolam, then lorazepam. Clonazepam was used among 53.33%, 60%, and 46.67% of the studied patients in group A, B, and C respectively. Also, alprazolam was used among 26.67%, 26.67%, and 33.33% of patients in group A, B, C respectively. Also, lorazepam was used among 20%, 13.33%, and 20% of the studied patients in the studied groups respectively. We found that the duration of benzodiazepine intake in the studied patients ranged from 2 to 7 years, with a mean duration of 3.47%, 3.33%, and 3.6% in group A, B, and C respectively. The studied patients were switched to equivalent doses of oxazepam. Doses varied from 80 to 480 milligrams per day. This graph shows the comparison between the three groups, A, B, and C, as plotted by blue, green, and red lines. And regarding the occurrence, appearance, disappearance, and peak of withdrawal symptoms according to the benzodiazepine withdrawal symptom questionnaire in the detoxification phase. And we can see that the best situation is for group A, which is flumazenil group, regarding the onset, peak, and disappearance of withdrawal symptoms. Then the worst situation is for group B, and with group C with a midway situation. Regarding anxiety, as measured by Hamilton Anxiety Rating Scale, also we found that the group A, which is plotted by the blue, is the best regarding the level of anxiety, which is fading quickly to reach to a minimum level at the end of the detoxification phase. And also, the worst situation is for group A, B, with the red line. Group A is called flumazenil group, group A. Group B is called the oxazepam tapering group, and group C is called the abrupt discontinuation and the replacement group. Also, regarding measurement of depression, it shows the same picture like anxiety, with the best situation for group A, which is the flumazenil group. Craving for benzodiazepine was the best shows the best result also for group A, which is for flumazenil group, and the worst result for group C. For group B, group A shows the best result, and group A shows the best result, and group B shows the worst result. Measurements of systolic blood pressure also during the withdrawal period shows the same, and measurement of the heart rate during the withdrawal period or the detoxification phase shows the same picture. After 15 days from the end of detoxification phase, relapse rate were 33.33, 60, and 40 in the group A, B, and C respectively, while they were 53.33, 80, and 63 respectively after 30 days from the end of detoxification phase. There were no significant difference between the three studied groups A, B, and C in the mean ages, age of onset, dose, and duration of benzodiazepines intake of the relapsed patients. So, the common management of benzodiazepine dependence involves either gradual tapering of the drug or sudden cessation with a switching to a longer half-life benzodiazepine or adjunctive medication. Initially, flumazenil, as we know, was considered as a pure antagonist. Later on, subsequent work in both animals and humans has shown that flumazenil is a mixed agonist-antagonist, partly dose-dependent. So, this study agrees with the results of other studies which reported that flumazenil infusion was effective in reducing withdrawal syndromes in benzodiazepine-dependent patients, not only for those in toxicity, and was capable to reduce anxiety level and craving during detoxification period, as well as inhibited the cardiovascular changes associated with the withdrawal syndrome. Flumazenil effect may be due to tolerance reversal and attenuation of withdrawal symptoms, anxiety, and craving mediated by normalization and upregulation of benzodiazepine receptors, facilitating coupling of the GABA-A receptors and benzodiazepine receptors complexes. Also, flumazenil can reset the benzodiazepine receptor set point that is shifted to the inverse agonist direction by chronic use of benzodiazepines, and to increase receptor sensitivity, which allows flumazenil to exert its weak partial agonist activity with possible enhanced efficacy. Finally, the capability of flumazenil to attenuate the urge to take benzodiazepine can be explained also by this partial agonist activity. Similarly, the effectiveness of low-dose oxazepam, which was given in the first 3 days of detoxification phase in Group A, administered in Group A patients together with flumazenil on the first 3 nights during the detoxification phase, could have been enhanced by receptor upregulation. The high relapse rates found in benzodiazepine-dependent patients treated with oxazepam tapering only could be attributed to the high craving scores, especially on the last days of detoxification phase, and more consistent withdrawal symptoms. This coincides also with the observation of other studies showed that the early stages of withdrawal are more tolerable than the later and final stages. In conclusion, flumazenil infusion with low doses of oxazepam appear to be more effective in controlling withdrawal symptoms after benzodiazepine discontinuation, with less incidence of relapse than oxazepam tapering or abrupt oxazepam discontinuation with symptomatic treatment. On the other side, oxazepam tapering over 8 days proved to be the worst of the detoxification methods regarding severity of withdrawal symptoms and incidence of relapse. Finally, I want to thank my collaborators, Dr. Dua El-Gharabawi, Dr. Ines El-Mahallawi, Dr. Iman Draz, Dr. Aisha Maqlad from the Forensic and Toxicology Department, also the staff members of Forensic and Toxicology and the Neuropsychiatry Department. Thank you very much.
Do you have any questions?
Yes, sir. I would like to first of all, it's a very nice study. My question is, you see, in the United States, for 750,000 people try to commit suicide each year, and about 30,000 are successful in committing suicide. This particularly happens to people who are you had any condition where people committed suicide?
Yes. During the discontinuation period of benzodiazepine, we saw patients highly depressed, suffering from severe degree of depression, even with suicidal tendency and suicidal trials. The comprehensive methods we used to treat benzodiazepine dependence, especially when the patient discontinues benzodiazepine, is to stop, to taper the drug and to give a replacement therapy. This is regarding the pharmacotherapy, but it is supported also by a comprehensive psychotherapy and psychosocial rehabilitation. Even this patient, as you know, necessitates hospitalization and even sometimes ICU admission.
It's interesting that these drugs have a very low marker safety and they are very low therapeutic index, and maximum amount of deaths have occurred because even when they are not taking, then there is dependency, but when they are taking, as you also mentioned, so you have a very comprehensive unit there people are maybe the cardiac function because they cause toxicity,
Yes. Yes.
cardiothoxicity, osteoporosis. So my question to you is that was there a specific age group where you find maximum number of patients as sex offenders?
In our sample, we found that in our sample it is common from the 3rd to 5th decade of life.
Because they have problem with sleep or something?
Yes.
Yeah.
Yeah. The motives for use, we find that lifestyle stresses and frustration become ranked number 1, and then peer pressure, and then relationship problem, and then lastly sleep problem.
In Ramadan, can you say about how many Ramadan do you administer to the patient? How many and how often?
Yeah. For 1 week, we administered in this research 1 milligram per day divided in 2 doses. The patient, yeah, intravenous infusion over 4 hours.
Over 4 hours?
Yeah. Thank you. Thank you very much.